Supracondylar humeral fractures. Supracondylar fractures are one of the most common traumatic fractures seen in children, most commonly between 5 and 7 years of age from fall on outstretched hand. There are two types, extension type and flexion type. Extension type constitutes almost 95% and flexion type less than 5%. Extension type is because of fall on outstretched hand. Flexion type is because of fall on directly on the olecranon. Associated injuries. Anterior intraosseous nerve neuropraxia, the most common nerve palsy seen with the supracondylar humerus fractures. Radial nerve palsy, second most common neuropraxia. Ulnar nerve palsy, seen with a flexion type of patterns. Vascular compromise is seen in 5 to 17% of patients. For nerve injuries, further diagnostic studies are not indicated in the acute setting. No need to do any nerve conduction studies or anything in the acute setting. Clinical presentation and investigations. Symptoms and signs. Pain, refusal to move the elbow, deformity and swelling. These are the complaints with which parents bring children to the emergency. When child comes to the emergency, you have to do X-ray of the distal humerus, not the elbow or the forearm with the elbow or arm with the elbow. You have to do X-ray of the distal humerus, strict AP and lateral. In that you can see a posterior fat pad sign, which is a highly suggestive of occurred fracture around the elbow joint. If it is displaced fracture, you will see the displacement. In the X-ray, you have to see anterior humeral line that should intersect the middle thread of the capitulum in children more than 5 years old and touches the capital in children less than 5 years old. And Bowman's angle is created by drawing a line parallel to the longitudinal axis of the humeral shaft and a line along the lateral condylar physis as viewed on the AP image. Normally it is 70 to 75 degrees. Deviation of more than 5 to 10 degrees indicates a coronal plane deformity and should not be accepted. Gartland classification. This applies to the both flexion and extension type of supracondylar fractures. Type 1 is non-displaced and it is usually treated with the cast immobilization, but if there is a medial comminution, then it leads to the varus deformity and it is technically not a type 1 fracture. It requires close reduction and pinning. Type 1 with the medial comminution. Type 2 is displaced. Deformity is in the sagittal plane only. Posterior cortex and posterior periosteal hinge is intact. Type 3 displaced, often in 2 or 3 planes, treated most commonly with a close reduction, percutaneous pinning or open reduction if required. Type 4, there is a complete periosteal disruption is there with instability in flexion and extension, treated commonly by close reduction, percutaneous pinning or open reduction and pinning if required. There is a clarity and treatment depending upon the type of fracture. Type 1 fracture, there is no medial comminution, treated by above elbow slab. If there is medial comminution, you have to reduce and put a K-wire. Type 3 and 4, close reduction or open reduction and K-wire fixation. But for type 2, there is still some controversy, some confusion is there. The long-term results of non-operative treatment of type 2 fractures show a propensity to varus alignment, hyperextension and lack of flexion, leading many surgeons to fix these operatively, especially when rotation is present. Obesity. Obesity is not only a problem of middle age and old age, now it is becoming a problem in younger children also. There is one study on obesity and supracondylar fractures in JBGS 2014. Obesity has been shown to increase the risks of nerve palsy, fracture complexity and complications. Obesity is associated with more complex supracondylar humeral fractures. Vascular status. You have to examine the pulse immediately after seeing the child. After reduction, either open, close reduction or in emergency, you have to feel the pulse at the priority. Vascular status is assessed by pulses, by palpation and Doppler. Temperature, capillary refill rate less than 2 to 3 seconds and comparable to other sides. Always you have to compare with the other side. And motor function. If the pulses are not palpable, there is no role for angiography. Pre-reduction angiography is not recommended, and this angiography test should not delay the fracture reduction in the pulseless limb following supracondylar humerus fracture. You have to reduce the fracture immediately in the emergency only if there is a pulselessness. Lack of palpable radial pulse. Is a vascular exploration necessary? If palpable pulses don't return, but the limb is warm and pink and or pulses are Dopplerable, the patient may be observed for 24 to 48 hours to assure perfusion and rule out compartment syndrome. Operative exploration is still preferred by many surgeons, but long-term follow-up studies suggest that exploration is not mandatory as long as arm is clinically well perfused. The lack of palpable radial pulse after close reduction and percutaneous pinning was not an absolute indication to proceed with a vascular exploration if clinical findings suggest the limb is perfused. After an average of 20 months of follow-up, children with perfused pulseless supracondylar humerus fractures that had been treated with a close reduction, percutaneous pinning and observation demonstrated a palpable distal radial pulse, normal growth of the arm and good or excellent functional outcomes. Nerve injuries. Nerve and artery injuries frequently coexist in the setting of supracondylar humeral fractures. The presence of an isolated anterior interosseous nerve palsy does not make the reduction and pinning more urgent, but the presence of a median nerve deficit should increase the index of suspicion for compartment syndrome. Presence of an ulnar nerve deficit increases the chances that the patient will need the open reduction. Pinning. There are two types of techniques are there: lateral only pinning, crossed pinning. The lateral only pinning decreases the slight risk of ulnar nerve impingement and is the most commonly used technique nowadays. Crossed pinning has shown subtle evidence of increased stability compared with the lateral pinning and is still used in some fracture patterns. I usually prefer a crossed pinning because it gives more stable fixation. Crossed configuration was stable in all patients, whereas lateral method was less stable in 20% of cases. This is a study published in Journal of Ortho Trauma in 2016. Intra-articular injection. The intra-articular injection of 0.25% bupivacaine significantly improves the post-operative pain control following the close reduction and percutaneous pinning of supracondylar humeral fractures in pediatric patients. Post-operative range of motion. An initial rapid recovery in elbow motion can be expected after supracondylar humeral fractures in a child, followed by a progressive improvement for up to 1 year after the injury. This motion recovery is slower in older patients and in those with more severe injuries. Return to activity and elbow motion improvements are not significantly helped by formal physical therapy. Coming to the complications. Pin migration, infection are complications of operative procedure. Cubitus valgus, cubitus varus are another two complications. Cubitus varus is caused by fracture, varus malunion, especially in a medial comminution pattern, and it is not caused by growth disturbance. Recurvatum, nerve palsy from injury usually resolves. Nerves rarely torn in supracondylar fractures. Vascular injury, Volkmann's ischemic contracture may result from elbow hyperflexion casting.